Good afternoon, everybody. Thank you so much for joining today's webinar. We're just waiting for everyone to join us, and we'll get started in a few moments. Everyone will be placed on mute as they join. And we'll be using the Q&A function for questions, so we do encourage you to send in your questions throughout the session. As a reminder, the webinar is being recorded and will be made available to everyone that's signed up and will be shared on our webpage. So do send in your questions. We'll have plenty of time for questions at the end. So without further ado, I'm going to ask Ian to introduce our session. Thank you.
Hello. This summer, we learnt 3 new facts about long COVID. My name's Ian Bernstein, Clinical Director for Musculoskeletal Health at NHS England, London region, and I'm chairing today's webinar about long COVID recovery in the Connect Health Change series. This popular webinar series usually attracts about 200 delegates, and we've got over 400 registered for today. The biographies for the speakers today and the recordings and transcripts of the Q&A of all the webinars are on the Connect Health Change webpage. Just a note that all our speakers are speaking in a personal capacity rather than representing their organisations. I'm going to showcase our next 2 webinars in October and November. The first will cover the role of virtual consultations following the opening up of services, and the second will cover how COVID impacted both unwarranted variation and inequalities in health outcomes. So back to today's session. Long COVID is the colloquial name given to persistent symptoms following COVID-19 infection. Post-COVID-19 syndrome refers to signs and symptoms that develop during or after an infection consistent with COVID-19, which continue for more than 12 weeks and are not explained by an alternative diagnosis. Most people recover from COVID in a few weeks. However, some people continue to experience continuous, relapsing or recurring symptoms for months after contracting the virus. Currently, there are an estimated 643,000 people in the UK who have self-reported long COVID, which is adversely affecting their day-to-day activities. So, the 3 new facts we learnt this summer about long COVID are, firstly, the coronavirus infection survey showed that long COVID may be less common than we originally thought. 12% of people self-report ongoing symptoms at 12 weeks following infection, and 7% of people continue to have limitation of their activities at 12 weeks following infection. Secondly, a study by Arsenian colleagues suggests that there may be a new syndrome that the authors have dubbed as fibro-COVID. They observed a cluster of people presenting with chronic widespread pain triggered following COVID infection, particularly in people who had had more severe COVID. And this syndrome, unlike traditional fibromyalgia, affects men and obese people more commonly. Thirdly, and arguably the most compelling fact from the Zoe app group, is that the odds of developing long COVID are probably halved by having 2 COVID vaccinations, and this is on top of the reduced risk of contracting COVID in the first place following vaccination. And in people aged 18 to 59, the odds of developing long COVID may be reduced even more compared to those who are unvaccinated or incompletely vaccinated. So the evidence to effectively support people living with long COVID is still emerging, particularly around managing fatigue, breathlessness, and muscle pain. This webinar, and the agendas on the screen, aims to provide an update on the latest expert opinion and evidence base. The panel will set out the key challenges and priorities for providing services to deliver personalised care to support recovery. It gives me great pleasure to introduce our first speaker, Rachel Moses, OBE, consultant respiratory physiotherapist and the president-elect of the British Thoracic Society. Her presentation will focus on the management of fatigue from an expert physiotherapy perspective. Rachel.
Thank you so much, Ian. So hi, I'm Rachel and I am a respiratory physio, and I'm going to talk about what I know about long COVID. And I have to say, the only real experts in this condition are people with lived experience, and I'm so fortunate that I don't have that. But what I do have is really close relationships with the support group, so I'm incredibly grateful for those, for the education that they've provided. Next slide, please. Now, I'm sure people are really sick about hearing about COVID-19, but I feel it's a duty of care as a respiratory clinician to remind us all of this data. In one day, in a single 24-hour period, this data is from Sunday when we had to hand the slides in, over 30,000 people were diagnosed with COVID, over 7,000 requiring hospital care, and sadly 58 people died in one day. COVID is not over, so please continue to do everything you can to reduce the transmission. Next slide, please. Despite most of the focus on acute management of COVID-19 very early on in this pandemic, we were already starting to see persistent symptoms for some patients, and this study has been widely referenced. It's from Italy. The data set's from May 2020, and it was published in the same in July. So even back then, researchers were looking at the longer term effects of COVID-19, and this was because some of the experts in this field, particularly those from the ME/CSF community and from what we knew about other viral illnesses, we knew that fatigue and breathlessness could be a real trigger for ongoing symptoms. They looked at the follow-up of 143 patients in this study around 3 months after hospitalisation, and as what was predicted by some, fatigue and breathlessness was an ongoing symptom. Next slide, please. So where are we now with definition? Ian touched on this. So NICE, SIGN and the RCGP have collectively come up with this definition that I'll let you read on the slide. It's described as a cluster of symptoms that persist for more than 12 weeks and cannot be explained by any other diagnoses. And we do see some people suffering from specific conditions post-acute infection. And this is why a real multi-system holistic assessment is essential. Now, as much as the etiology and pathophysiology causes of long COVID remain under discussion or unsure, the current hypotheses are many. This viral persistent, this communed hyperactive immune response, cellular metabolic dysfunction we're seeing, autoantibodies, neurological dysfunction, neuroimmunology, neurological inflammation, and of course ongoing organ impairment for some, including cardiac dysfunction and impairment. And we've seen the commissioning guidance now for the post-COVID clinics published. And there is further recommendations coming out around rehab and the commissioned services as well. So I cannot stress how important it is that people who have these persistent symptoms get referred into a long COVID clinic where indicated. Next slide, please. Now, this is a great study that looks at an international cohort where they analysed responses from 3,762 participants from 56 countries. They all had confirmed or suspected COVID-19 with an illness duration of 28 days or more. Now, you can see some of the demographics here. A large proportion were women. The majority were of working or caring age and of white ethnicity, and a smaller proportion were healthcare workers. Next slide, please. Now, during their illnesses, participants experienced on average 56 symptoms over 9 organ systems, and the most frequent symptom by far after 6 months were fatigue, post-exertional malaise and cognitive dysfunction. Next slide, please. Now, these symptoms were classified as these 3 cluster type symptoms, each with a characteristic temporal profile you can see, and they varied in prevalence over time. Next slide, please. Now, the majority of respondents, over 90% of respondents, declared their time to recovery exceeded 35 weeks, with the most common symptom being fatigue. Next slide, please. Over 86% of respondents experienced relapses, and I want you all to listen to this next bit. These were primarily triggered by exercise, physical or mental activity, and stress. So over 86% of people experienced relapses due to those causes. And over 86% of unrecovered respondents were experiencing fatigue at the time of the survey, compared to 44% who had recovered. So fatigue being a major limiting factor to recovery. Next slide, please. Now, yellow equals not recovered, blue equals recovered. And in 45% of respondents, so 1,700 people, they required a reduced return to work schedule. And an additional 22%, so over 800 respondents, were not working due to ongoing illness. And cognitive dysfunction was really common across all age groups at about 88% of all respondents. Next slide, please. Now, I don't have time to talk about all the interventions and what we know works and doesn't work with long COVID patients. The physiotherapists for long COVID have described long COVID as a multidimensional, episodic and unpredictable disease in nature. And I believe this really accurately describes what we're seeing in people living with long COVID, as well as the published data. Now, fatigue is the most common symptom of long COVID, that's undeniable. And this can also impact on cognition and mental health. And we know that cognitive exertion can be really tiring for people with fatigue. And that includes simple things, everyday activities such as reading, watching TV, having conversations. And this should really be considered when implementing energy conservation strategies such as pacing. And that's why stop, rest and pace is a really important tool to tell people and to remind people with ongoing symptoms, including fatigue. Changes to smell and taste can have a real significant impact on nutritional intake, and this can further delay recovery and fatigue. And advice on dysautonomia is really important because we see real problems with dysregulation of heart rate, blood pressure, and postural orthostatic tachycardia syndrome is a form of dysautonomia, and this is characterised by an abnormal increase in heart rate when someone's been sitting or lying down. It may cause dizziness or fainting, and we know this is triggered by bacterial or viral infections. I've mentioned return to work plans. This needs to be individualised. The classic 4-week get back to work just doesn't work for a lot of these patients. And my final point on exercise only being recommended as a rehabilitation intervention for people not experiencing post-exertional symptom exacerbation. Now, a huge amount of resources are on the Long COVID SOS website, the Long COVID physios, physios for ME, physios for BPD, the Royal College of OT, and long COVID kids, because this disease affects people of all ages. Hope I've kept to time there, Ian.
Fantastic, Rachel, and thank you for a whistle-stop tour and bringing us up to date on the epidemiology. Rachel, you mentioned that exercise is not recommended for those suffering long COVID that have post-exertional symptom exacerbation. I wondered if you could just expand on that.
Yeah, that's a huge question and a short time to answer. But in a nutshell, as healthcare professionals, we will always encourage people to be as active as we possibly can, because we know inactivity is detrimental and dangerous. However, if someone has significant symptoms following a viral illness and post-exertional symptom exacerbation is present, so people do things, they do activities, and they're absolutely flawed for hours, days, months afterwards. We know from other conditions such as the ME/CSF community that graded exercise therapy for this patient population can also be detrimental and dangerous. Therefore, if someone has post-exertional symptom exacerbation, can be called post-exertional malaise, then they need to have a thorough assessment. They need to potentially have like a fatigue management plan, a fatigue diary, and they need to have energy conservation strategies as well as an activity planner. It might include heart rate monitors, it might include dietary advice, sleep hygiene, all of these really basic things that we tend to sometimes forget. We go straight to the other end, and blanket exercise provision is not helpful. So I would signpost to the websites already mentioned as well for that.
Brilliant. Thank you so much. And I'm just going to check in with Ali. Are there any questions on the chat for Rachel?
Yes, there are. There was one in particular. There was an item on the news that one real outcome of COVID infection in people who were healthy prior to the infection is new onset diabetes. Do you have any information about that?
So that I can certainly signpost. That's a massive question. Ian, I don't know if you want to come in. There is a link, but the causative link is unsure, and it could be related to some of the ongoing viral persistence and the inflammatory inflammatory response that we see. But that's a huge question.
Yes, I think it's a difficult question. I think there's so much unknown here, but it's likely to be autoimmune mediated, and I think watch this space. Okay, so we move now to Dr. James Hull, who is a consultant respiratory physician at the Royal Brompton Hospital, and he's here to give us an expert medical perspective with a particular focus on breathlessness. So, James.
Well, thanks very much, Ian, and it's great to be with you on this webinar. If I can have the next slide, please. So we all certainly know now, after 18 months of living with this novel coronavirus, what a devastating impact it has on the lung. Here you see a chest X-ray, which doesn't really give a lot away, but if I could just play the animation, you'll see in this individual with moderate to severe disease, the widespread impact it has on the lung with these so-called ground glass or inflammatory changes as cells sweep into the air spaces to try and mop up and attack and help clear the lung from this virus. And of course, that has consequences in terms of breathlessness, low oxygen levels and coughing. Next animation, please. And you can see also from other types of imaging that we found that this condition affects the lung in other ways. So here you see a blood clot sitting in the main pulmonary artery, and we've realized now that there is a high prevalence of unexpected blood clots in this condition. And in the picture below, you see how this can affect the lung in other ways and have more chronic or long-term consequences for lung health. Next slide, please. But of course, we're here to talk about long-term or long COVID symptoms and those that persist. And this data from a survey conducted on behalf of Asthma UK and the British Lung Foundation, two excellent charities in respiratory medicine, surveyed individuals who were struggling with long COVID symptoms. And you can see how breathing problems were a really key issue, as outlined as well by Rachel in the previous talk. And that's irrespective of whether you were hospitalized with this condition or not. Breathing problems are a key and pervasive problem. Next slide, please. But that only really gives us a hint at what the problem is, because actually when you look at a graph, you think everyone might have the same type of breathlessness. But actually when you drill down, as they did in this paper, and actually ask patients, what are the type of problems that you get, you see a very different story. And while you might expect that people follow a recovery course, which is gradual and progressive, and day by day people feel better, actually the literature, and certainly my clinical experience from helping people with this, is that it actually covers a very fluctuating course. So people can feel very good, and then as you see in this patient description, it's one step forwards and then 3 steps back. And that leads to a lot of uncertainty, especially if you've been very highly functioning and doing very well in work and sport and exercise previously, and you're unable to really predict how you're going to feel on a day-to-day basis, and you feel very breathless. It's devastating. Next slide, please. So when I see individuals with ongoing breathlessness, which is unexplained or that people haven't been able to get an answer, of course, the patients who are affected by this condition really want to know, has something been missed? Could I have a long-term pathological explanation relating to the original infection? Could it be blood clots? Could it be fibrosis on the lung? And so it's important that people are reassured that the best tests have been done to rule out those sorts of manifestations. We know that COVID causes inflammation in the heart, and we also know there can be blood abnormalities such as anemia, which can cause breathlessness. Next click, please. But the literature that is emerging, and certainly over the last 6 months, actually suggests that there is a disconnect between people's breathlessness and what you might find on objective tests. So there may be a disconnect between imaging findings. There may be a disconnect between lung function findings. And so the individual who's struggling with real breathlessness, struggling to return to work, struggling to return to exercise, is repeatedly told that the tests don't show any abnormality, and that should simply be enough to reassure them. And yes, of course it isn't. And as you would know yourself if you're in that situation, those type of statements aren't particularly reassuring. Next slide, please. So what do we do to try and unpick this and help people move forward? Well, as a physiologist, I always lean back to physiology, and these are the different types of processes which are organ systems which are involved in helping people do things and contribute to the etiology of breathlessness. Problems with gas exchange, problems with cardiac function, problems with the way that the muscles work. And actually, there's a lot of data emerging now that suggests that any one of these processes might be affected in different people with unexplained post-COVID breathlessness. And we don't really have the full answer, but next animation, please. Next animation. But in interrogating, next one, sorry, interrogating these types of processes in the form of an exercise test or some sort of physiological assessment during exercise can really help us unpick where the problem might lie. Now, there's a picture of the brain in the top left-hand corner, because overall, despite all these different organs having to speak to each other and transport oxygen to the muscle, there has to be an interaction with the brain in the way that we perceive symptoms, and that's particularly important in breathlessness. So when you perform any test, it's always important to go back to how people perceive that breathlessness in the context of any type of test or challenge that you might perform. And that's key, I think, in trying to move this forward. So if I could just have my final slide. I'm going to summarize that now and just say, look, I mean, you know, we know that respiratory problems are very prevalent and the key driver to disease in the acute phase. They're highly prevalent in the post-COVID or long COVID syndromes. They may be explained by underlying pathology. It's really important to reassure people that you've considered and done a thorough assessment of that. Otherwise, it's a difficult conversation to detect the pathology down the line when you've been trying to use other strategies to help their breathlessness. Next click, please. But I would say that in the context of unexplained symptoms, and in long COVID, if you've ruled out of the pathological explanation, you need to understand how those symptoms are arising, how they're fluctuating. This isn't just a question of arranging a bunch of tests and reassuring people that the tests are normal, and understanding that in the context of the individual to help pace them and understand what the goals and strategies are to move them forward. I'll stop there. Thank you.
James, thank you very much indeed. And a couple of questions for you. So the first one is, what in your opinion is the biggest challenge for helping people with breathing issues who have long COVID?
Well, you might think it's something like, you know, getting access to very flash scans, such as some of these perfusion MRI scans that lots of people email me about and say, why can't I have that scan like it was shown in the research studies in Oxford to be so transformative in terms of helping people understand post-COVID breathlessness? The reality for me is simply trying to get people through logical, simple frontline investigations to reassure them, and then getting patients particularly to the right type of expert to help them. And by that largely I mean people like respiratory physiotherapists, OTs and others who really understand how to help people with breathlessness. And there's a huge dearth and shortage of those types of experts right across the NHS. And so we need to be able to marry those two things together and ask the payers and the organisation to try and organise and streamline those services to patients.
Thank you. And a question from the chat is, do people tend to continue having drop in their oxygen saturation when mobilizing when they've got long COVID as opposed to acute COVID?
Yeah, in some way that they can do. In some way that depends on the type of initial lung insult. So for instance, if you're recovering from a fairly severe pneumonic process, it can take some time for those stats to be improving. What I would say is that any sudden reduction in that or new reduction needs to be taken very seriously and considered for other causes. And I've already mentioned things like blood clots, which actually can sneak up, especially people who have been immobilized and can't walk very far, because it makes your blood more likely to clot and get things like DVTs, etc.
Brilliant. I've got one more question, which is, I think I'm going to also bring Rachel in here if we can just line her up for this. And James, you mentioned about, you know, you showed the picture of the brain in the top corner of that slide and said that that was important. And you then went on to describe some of the physiological tests. I'm seeing quite a lot of people with dysfunctional breathing where we wouldn't necessarily see an abnormality on physiological testing. And I just wondered, I'm going to come to James first and then to Rachel to comment on how common that is, how you might detect it. So James, is this something that you see in your
I do. I mean, it's incredibly prevalent. I mean, of course, I see a slanted view of the world because typically people refer me patients where they've had lots of tests completed to start with and they're still not being able to explain the symptoms. But I see it as the #1 cause for ongoing, unexplained or disproportionate respiratory symptoms in this context.
Brilliant. And so coming to Rachel, if you want to come off mute and perhaps just explain to us what dysfunctional breathing is and you know, how you might diagnose it.
Yeah, so this is a whole seminar in itself, but dysfunctional breathing generally is caused by over-breathing or breathing in a way, or breathing more than we need to. It's caused by a number of factors. It's an umbrella, and there are specialists, you know, Jim's got a specialist team that can help manage this. But why is there a link with dysfunctional breathing and long COVID? Probably, my personal opinion, because fatigue is highly prevalent, because ongoing symptoms of breathlessness, and there might be a pathophysiological cause of that, but also probably because of deconditioning, coupled in with everything that comes with that. So social isolation. I don't want to focus on anxiety because a lot of clinicians can sometimes say this patient's anxious, and that's not necessarily true. But there is a psychological element to this, and this is why breathing pattern retraining, you know, normal patterns of breathing is really important, combined with everything else. But yes, say physios can treat this completely. It's completely treatable. We see it in other conditions.
Lovely, great. And so I suppose just to bear in mind that dysfunctional breathing is a common cause of breathlessness in long COVID. Thank you. So we're going to move to Razia Bhatti Ali, who is a consultant clinical psychologist with Connect Health Pain Services. And she is living with long COVID, and she's going to tell us about her own personal experience. And I think I'm just going to, before you come on the line, just reflect some of the comments we've had in the chat, you know, from patients who are on the webinar. I've been suffering for 18 months now, but all my tests are normal. Very depressing, feel ignored as tests don't indicate anything. You know, this seems to be a very common pattern that perhaps people aren't feeling believed. So Razia, over to you.
Thank you, Ian. So today I'm going to talk about my experience of long COVID and how it affected me both physically and psychologically. It actually feels quite strange sitting here in front of a large, albeit remote audience, talking about my own health issues when normally I would be discussing other people's health. So prior to the pandemic, I considered myself to be healthy and always endeavoured to look after myself with healthy lifestyle choices. And other than the odd cold, I was healthy and active, rarely needing to see a GP. So when the pandemic began, I believed that by following all the necessary precautions, I would be safe and only worried for the health of my loved ones. But one thing amongst many that the COVID-19 pandemic did was to challenge my own fallacious belief that I or anybody else is invincible when it comes to this virus. So at the beginning of January this year, whilst in a lockdown bubble with my immediate family, my eldest daughter and I developed COVID-19 symptoms and tested positive. We were both unwell with high fever, persistent cough, headaches, deep aching in the muscles and bones. And thankfully, no one else in my immediate family tested positive. I stayed in bed for about 3 or 4 days and then felt I was recovering. I was grateful that my daughter and I had not suffered any respiratory difficulties or complications needing medical help. So other than rest and paracetamol, I didn't seek any medical attention and felt relieved that the symptoms were akin to a bad flu, even though it wasn't a pleasant experience. So after the initial bed rest, I was functioning fairly well, or so I thought. I was back to work, but noticed poor energy levels, brain fog, poor concentration and memory, and also blurring of my vision. And interestingly, my voice became husky, and still is actually. The fatigue was unlike anything I had ever experienced before. As soon as I finished work, I needed a nap, which sometimes lasted 2 hours or more until someone came to wake me. And this was very uncharacteristic of me. And while I knew my body needed the rest, it felt uncomfortable and lazy, and I was falling behind with my normal routines. The blurry vision that I experienced in the first few weeks post-COVID was quite frightening. It would be difficult. So when I'd logged on to my laptop for work, I was finding it hard to focus my vision and became worried that the virus may have damaged my sight. However, this symptom eased after a couple of months. I also started to become quite anxious about my poor concentration and memory, and I now understand firsthand that why many fibromyalgia patients describe as brain fog, the confusion, forgetfulness, a lack of focus and mental clarity, and just not being able to think clearly or even recall the words that you might be trying to get out. I try to exert myself with cognitive stimulation exercises and challenge myself by taking on extra mental tasks to keep busy with work, but I was truly struggling. The urge to push myself in a job that is mentally demanding was incredibly exhausting, so that the rest of my normal responsibilities and activities were neglected. I'm not proud to admit that I did binge on any available Netflix series at times when I just wanted to lay on the sofa and literally plunge myself into a world of escapism. Perhaps because long COVID was an emerging concept, I didn't discuss my symptoms with anyone outside of my home and only spoke to a few colleagues who were extremely validating. And then one day I was suddenly hit by a huge sense of overwhelming sadness and realised I have been experiencing low mood all along, but had instead focused on the physical and cognitive symptoms. I had also withdrawn from keeping in touch with others as I was afraid people might ask how I'm feeling. There was almost a fear about admitting to my vulnerability, as deep down I believed I should have recovered by now. I tried to understand my own symptoms as being a natural consequence of grief that I had simultaneously experienced following the death of two very dear family members who passed away at the time when I was ill with COVID, but recognised I was becoming emotionally and physically overwhelmed. The marked change in my energy levels and in my usual capabilities was truly frightening, a recurrent theme that our chronic pain patients often describe. Of course, because there's no established medical roadmap for recovery for long COVID, I didn't seek any outside help. However, once I became aware of the emotional whirlpool that I was being sucked into, I did take a step back and reverted back to the many tools and strategies that I teach others to boost my own mental and physical resilience. I knew I needed to trust my body's ability to heal at its own pace, given that there is little research on the virus and expected recoveries. I started to try to move past the sense of incapacity and started to take each day as it came, trying to establish boundaries, practice self-compassion and resting as much as I needed. And above all, I got into the habit of practicing gratitude daily, realising I was lucky not to end up in hospital, lucky to still be able to work, lucky that because I am working remotely, I didn't have to exert myself with the daily commute, lucky my daughter's symptoms were not severe, and lucky that we were both alive. Talking to patients and some colleagues who have also experienced long COVID, the common themes reported were an increase in anxiety and depression, brain fog, memory and concentration issues, headaches, lower back pain, pain in muscles and joints, tiredness, weakness, fatigue, tachycardia and pounding in the chest, and loss of taste and smell and so forth. For many of our chronic pain patients, the wide-ranging and potentially serious symptoms were causing intense health anxiety, and I was talking to them about this. Some patients were aggrieved that they were not getting any help from their GP and were being advised that the symptoms were due to the virus which needed to run its course. And some patients said that their families were also telling them that it's all in your head. Many patients said that they were being dismissed with the label of anxiety and being invalidated. This could well be partly due to a lack of knowledge and clinical guidance on how to manage chronic COVID-19, as well as burnout or clinician anxiety when faced with an unknown entity of which symptoms and treatment are not yet fully understood. Given my own experience and that of others, I think without a doubt there is a need for a service to support people with long COVID, as well as further research and evaluation. I'll stop there.
Razia, thank you for that very touching description of the symptoms that you've had and how you've coped. In retrospect, what might have helped you in your recovery? What could you have done differently?
I think it would have helped if I had talked to people a lot more, you know, sort of shared my symptoms and sort of being able to normalise that other people with long COVID were experiencing similar symptoms. I think I was quite hard on myself, actually, with this belief I had that I'm a healthy person, I shouldn't be feeling like this. And that's where I think the self-compassion helped, when I started to be kinder to myself and say, look, this is an unknown entity. It's something that I'm going to have to sort of work through, and I need to talk to people about it. And that's when I did start to share my feelings a lot more. And also my faith really helped me. My faith is very strong. So I was using a lot of prayer and gratitude and also taking I'm a strong believer of trusting God, but also tether your camel. So I was also praying, but also making sure I'm looking after my body and resting as much as I needed to, pacing myself, doing things in a way that was more holistic and helpful for my own body and mind and spirit.
And are there any particular places? I mean, some people may not have had a huge social network even before COVID. Are there any particular places you've mentioned, faith, perhaps, being in contact with church or mosque or synagogue or whatever, but are there any other any websites that you would recommend where you might get support, things that you found helpful?
Quite honestly, it was more the psychological knowledge I had, and using my own, psychological base to apply on myself. For a change, I was practicing what I preach, and sort of like using the techniques I've learned from various therapies. It wasn't so much websites I was using. I did get the opportunity to sort of like attend lots of webinars, because there's a lot of free webinars on looking after the body. And I at the time I had before the pandemic, I had started doing this herbal healing course online, and I was using a lot of the stuff that I learned from there to sort of like incorporate good diet, supplements, sort of looking at kitchen herbs and spices to sort of like reduce inflammation. So they were the sort of things that I tried to use to help myself.
Okay. And you mentioned something about, feeling that you'd heard that other people mentioned that they weren't validated. Tell us a little bit more about that and what we can do as a clinical community to counter that.
I think the thing is that somebody mentioned earlier on as well that a lot of people might be confused as being anxious. And yes, anxiety is a big part of being ill, because especially if you've never experienced something like this, anxiety is going to be really prominent. But a lot of people saying that people weren't taking their symptoms seriously and saying that, well, you should be over it. And I think with the chronic pain patients that I work with, because they already have existing health conditions, anything additional that they were telling people, it was like, get on with it, you just need to work through it, it's just a virus, you'll be fine. And it was partly because there wasn't enough information about long COVID. It was an emerging concept, and that's why people were not really being taken seriously, I guess.
Great, thank you very much. And we're going to move now to Steve, and we'll come back to Razia in the plenary session. So Steve Tolan is the Allied Health Professional Lead for NHS England London region, and he's a physiotherapist by training, and he's going to describe to us the national challenge.
Hello. So if we go to the next slide. So what I just want to give is an overview of how services are broadly set up, and then just touch on some of the operational challenges for delivering these types of services. So the slide that I've just put up initially is a broad overview of roughly what we might expect in terms of services within a place, and there's variation around the country about the detail behind some of this, but this is a general picture of how the system may look. Now, I think what you can see is, just in response to one condition, this is quite a complex setup and interrelated system. And as part of that, it means that there's been time to pull some of this stuff together, and we've had to move quite rapidly in order to stand up these services. What I wanted to touch on, if we go on to the next slide, was just to talk through some of the timeline of this to give a picture of some of the complexity involved in some of this. So effectively in September 2020, the NHS was asked to establish long COVID assessment clinics. Now, what's important to note is that was asked of the NHS before, as we can see in October, long COVID was defined, and before, in actual fact, any commissioning guidance was available around this. So effectively, the NHS was asked to stand up clinics to do something, and then afterwards we've had to discover what it is those would be needed for. What we can see, and certainly from a London perspective, we then faced a period of disruption. So particularly long COVID in the early stages, in terms of workforce that we were looking to pull into this, was very respiratory focused, and obviously as we went into the second wave around Christmas, there's some very significant respiratory challenges, so more needs around intensive care and needing to draw workforce into different places. But since the second wave, we've had further opportunity to stand up services and to develop what we wanted to put in place. So, for example, in London, we have 17 specialist assessment clinics, but there's been further work to mature the general practice response and supporting general practitioners to understand what's required, how they can refer into these services, and then to think about how we could provide, importantly, the treatment. So the assessment clinics are all well and good, but they're not actually the real destination. The destination is to be able to receive the treatment and support that might be required in order to help people resolve the challenges that they're facing. And now, if we go to the next slide, the key thing that I wanted to draw out is the level of complexity and uncertainty that we're operating in. So I often talk about long COVID as being the ultimate wicked problem, and so we do have limited research evidence base, and particularly compared to what we would traditionally build services on. What that's meant is that we have heavily relied on, particularly in the early stages, to collecting stories like Razier's, to some clinical consensus, and then to some early insights from data collection, and also early insights from ongoing research. So people sharing the foothills of research before they're finished with it. We also know that there's been rounds of research funded by the NHS and NIHR funded research, and there's an announcement of multiple projects being funded in that way a couple of months ago. But in real terms, those won't deliver until next year. So from a traditional evidence-based perspective, we very much have relied on quality improvement, learning and iterating what we know, testing what we know, and evolving that as we progress. In terms of epidemiology, there isn't absolute clarity on that. So we have some insights from ONS, but we see the goalposts change at different times. There are questions about it, whether it's under reports or over reports. We have to take into account inequalities. So do ONS reporting take into account different communities' access to digital devices? We know lots of the research community collection of data about populations is very digital and app focused. Are there any digital inequalities being taken into account of that? But the way in which we approach the modelling is to use it as a question. So where we have these models and numbers is thinking about testing those to say, well, is that what we're seeing? If not, why not? And using that to understand in more detail. In terms of workforce, we have the particular challenge that the NHS in total only has a finite workforce resource. And if we take general practice as an example, there is very much being asked of general practice at the moment, whether it's vaccines or a whole range of other things. So the bandwidth, capability of general practice to respond to this as a condition, or for the rehab professions to be available in light of some of those other things that we're talking about. And health inequalities is a known tricky challenge. So not just around diverse populations and hesitant populations, but we know, for example, there are significant risks around diagnostic overshadowing. So people with learning disabilities, people experiencing homelessness, older populations where some of these symptoms, such as fatigue, could be discounted as something minor and not actually reviewed properly. Children and young people, we're still at the foothills of understanding the true picture and need with respect to children and young people, and then thinking about clinician education needs. So I think there's probably quite a lot of clinicians on this call, but very much thinking about how do we support clinicians to have the best knowledge to be able to engage in some of this, particularly as the education that we would want to provide will move. So the education we would provide on this today likely would be different to the education we will be providing in a year's time, because we know the research and the experience and various other stuff are changing as we go along. Competing priorities in the system. So what does happen if we experience another difficult winter period? And what will happen within the prioritisation of services, understanding that in real terms, we do only have a total number of NHS workforce, and how do we manage those competing priorities going forwards? And then thinking about the emerging needs of these populations. So one of the things that's been focused on more recently is the vocational rehab needs of this population. But in real terms, vocational rehab provision in England pre-pandemic isn't very big, and so it's thinking about how do we provide vocational support and rehab within the realistic resources available within the NHS. So it's very much an emerging and evolving picture. There are significant challenges, but for me, I think the greatest opportunity that we have here is the potential legacy from long COVID. So long COVID may continue as a long-term need of a pathway and a service, but what we know is that we haven't had robust complexity and morbidity pathways, and the strength of the long COVID pathway is it is based around the principle of physical, cognitive and mental health integration. And what I would say is, in my experience, there has been the broadest multidisciplinary and specialty input into development of long COVID pathways, great patient participation and patient leadership. And I think as well, I would reflect on the clinicians that I've certainly come across linked to long COVID as being incredibly passionate and dedicated to their patients, and a real keen ambition to focus on personalisation and ensuring that people get the individual support that they need. But with the wider clinical population, it's just very much thinking about how do we support them to raise their awareness and to adapt to an evolving pathway system and health economy linked to long COVID. So I think I'll leave it there.
Steve, thank you. Two quick questions for you. The first is, what do you see as the biggest challenge for operational delivery of these services at scale over the next 1 to 2 years?
So for me, it's around workforce capability and capacity. And so the issue is, and it's not just about whether you have enough money, it's whether you have enough people to deliver these. Now, the opportunity is to use some ingenuity and think about wider workforce, community assets, and patient groups, and think about best use of digital resources as well. But the key issue is we're not going to be able to grow some of the traditional workforce groups quick enough to keep up with demand, not just from this, but some of the very many things that the NHS needs to do. So I think there's lots of room for workforce ingenuity, and that's much needed. So I think that's going to be an opportunity going forwards.
Brilliant, Steve. And the last question really comes from the chat. There's a colleague who's asking about, what sort of initial tests might be indicated, maybe in a primary care setting or an assessment setting. And I wondered if you wanted to signpost to the any national resources, any learning resources that might.
Yeah, so there's some outlines in the national commissioning guidance. What I can say is, in the region, what we've tried to do to make life easier for general practice, understanding all these competing demands, is to try and build electronic health record templates that guide people around the expected diagnostic tests and tools that they might want to use. I think it is important that we show some kindness and generosity to general practice and make life as easy as we can for them, because they actually are experiencing a huge number of competing priorities and pressures. So things like where we can build infrastructure to make that easier to support clinical decision making, I think is a positive.
Thanks very much. So we move now to Karen Bradbury, who is the regional lead for clinical lead for Connect Health Pain Services, and she's talking about the challenges of developing a community long COVID model, focusing on self-management and primary care and vocational rehab. So Karen.
Oh, thank you, Ian. Hello, everybody. Could I have the first slide, please? Thank you. So I'm going to talk today about the challenges of developing a community long COVID model. And as we've heard from the previous speakers, COVID presented a unique challenge to the NHS, and the treatment and management of acute illness has now become quite well established. So whilst many patients are now deemed medically stable, the multitude of long-term side effects from the virus, as we've heard, and the long-term impact of the condition continue. And this is becoming a significant challenge for primary care. So as you can see from the slide, the NHS has set out its plan for 21-22 of how this funding should be used to best effect. And as you can see, they've identified 10 areas of priority. And there's an awful lot of work to be done, and the challenges of how we're going to be able to deliver this. Could I have the next slide, please? Thank you. So recently, some of this funding has been made available to NHS commissioners for community programmes. And as we were already, as a service, running a number of community chronic pain self-management programmes nationally, we were asked by a number of clinical commissioning groups to put together a model for a long COVID self-management programme which could be run in the community. Now, each area had different pathways, different models in secondary care, such as the long COVID clinics, but the need for self-management, that ongoing sort of treatment option, was really becoming evident. So just to give you an example, in one particular area, we were asked to design a community programme which patients from the long COVID service could be referred into. So from secondary care, into our service. They were looking at the programme being delivered remotely, largely with face-to-face provision if it was clinically required. So short term, they were looking for a continuation of what we were doing with our chronic pain patients in some ways, the biopsychosocial approach to a biopsychosocial programme, and the emphasis on empowering patients to manage long COVID holistically following their treatment in a secondary care long COVID clinic. And long term, what they were hoping to do was to reduce the burden on GP practice as cases continues to rise, and maybe to link in with existing persistent physical symptom services in the future, so that in time long COVID patients aren't just sort of lost. So like everyone else, we avidly read everything we could, but as Stephen has just sort of explained, no one really is an expert, no one has the answers. Evidence is quite scarce, and for sure things will change as we learn more. One of the big factors is there's no diagnostic test as such for COVID. You can have had a positive COVID result, but how do we really define long COVID? That has been attempted, but there will be challenges going forward. So with that in mind, we decided to maybe take a slightly alternative approach and build the service, if you like, from the bottom up. Many of the team have lived experience. We talked to staff members with that experience. They had family members with experience of COVID, friends, and also we had a number of patients coming into our community pain service who also were experiencing long COVID. We attended the MDT meetings with our local COVID clinic, our local COVID service in secondary care, to get a real understanding of the issues that patients were facing and agree on an appropriate referral criteria into a community self-management service. And so we asked people what the main issues were and how we could help them. And overwhelmingly, fatigue was the main issue, but adjustment to life after COVID was a challenge. And whilst medically patients were being told they were stable, they were really still struggling to adjust to the impact long COVID was having. The key themes were really making sense of it all, understanding the impact and how to manage it. The main theme that was coming out was the being listened to, being believed, communicating with health professionals, with work in particularly, and with also family and friends. Having a real plan, you know, how are we going to kind of recalibrate life in the short term and long term in line with what we value and looking towards those goals. And also that group support, connecting with others, decreasing the feelings of isolation that you have when you're suffering the effects of long COVID, and also gaining confidence or regaining confidence. Could I have the next slide, please? So we fortunately have a wealth of experience in the Northwest team and also in the wider team nationally. Our clinicians are trained in the biopsychosocial model. We have nurses, OTs, physio, CBT therapists, psychologists, and many of them have worked in specialist services such as chronic fatigue, CFSME, fibromyalgia, long-term condition management, and so on, in addition to having worked in pain services. We looked at the common themes, the differences, what was working well. We really tried to cover all bases. And we also looked at the elements of things like the psychological approaches, such as mindfulness, acceptance commitment therapy, compassion focused therapy, and cognitive behavioural therapy. So this theme of self-compassion, behaviour change, acceptance, values ran through all aspects of the programme. And we were looking also as well at the understanding the impact on work, sickness absence, and how that might affect things in terms of occupational health return to work. And also adding in the knowledge and skills that we had around lifestyle management, such as nutrition, hydration, diet, exercise, and so on. So we developed a core programme which could be adapted to the needs of both the commissioners and the patients, dependent on the COVID provision in the area, a programme that could be scaled up or scaled down as required. And the core of the programme was to offer a comprehensive biopsychosocial assessment, followed by a range of options which could include access to Your COVID Recovery online programme, you know, with support from the team, for those patients who were perhaps low risk or unable to commit to a programme. And for the majority of patients, there was the option of one-to-one appointments, the 6-week programme that we developed, and also an option of psychology CBT support and onward referral into the IAP services locally as required. We also have developed an Urdu version of the programme for this local particular area, and have Urdu speaking clinicians who can support the delivery, who have experience of running culturally adapted pain management programs across the region as well. So wherever possible, the course will be delivered remotely, as patients with fatigue, as we know, can really struggle to attend face-to-face appointments, and in different areas, different things will apply. Technology as well is an issue for a number of patients, language difficulties. So we're aware of all those things that may sort of affect the future and how we develop the courses, and we will bear those in mind going forward. So could I have the next slide, please? So the programme content in a nutshell, this is the sort of 6-week programme, which can also be developed, delivered individually. We've devised really a 10-step approach, which will hopefully give patients the skills to manage their condition and the confidence to make changes, recalibrate their lives and move forward. So the first point, gather knowledge about your self-condition, giving patients that real understanding of what long COVID is, the impact of the condition, and as much of evidence of the evidence base that we can for them to have a better understanding. The key factor from the start is understanding how to manage energy and reduce fatigue, as we know that's a predominant symptom. So it's that awareness of not just the physical energy, but the mental and emotional energy, and how that affects the cognitive burn of energy that we use, and the worrying about our condition, worrying about the future, how much that drains us as well. And we use sort of a traffic light system, red, amber, green, to grade activities so patients can become more aware of where their energy is being spent. The third point, increased activity, improve physical health, looking at pacing, setting baselines, increasing activity, not exercise. Every case is individual, as we said, we cannot prescribe one size fits all. Learning how to rest, sleep and relax, so sleep management, connecting with pleasurable activity, not the have to do things, but really enjoying things as well. So we look at managing thoughts and deciding what's important as well. Communication, of course, saying no when you need to, and communication with those at work as well. Being kind to yourself, managing flare-ups and keeping the motivation going. So we're going to obviously be evaluating the outcomes and feedback and making change to improve the service as we go along. Thank you.
Karen, thank you so much. And in fact, that was a lovely segue into my first question, which is, you know, how are you going to evaluate the services? How will we know if this is really helping beyond the natural recovery rate that we might see in some people?
So we're using a range of outcome measures. We're looking at the things like the shoulder fatigue scale, the EQ5D. We're looking at patient feedback. We're looking at the PSEC, some of the pain scores, which are appropriate if patients have pain. But I think it's really the patient feedback. What are they gaining from the course? How is that impacting their lives? How are they feeling?
Brilliant. And I wondered if you could just touch on we've heard from Steve about vocational rehab and also from Rachel. Is there any component of vocational rehab in this program? And if not, where would you signpost people?
So when we're looking at putting together a management plan, when we're looking at values, when we're looking at goals, that's where we would put in the vocational rehab as well. We're hoping that we will also be able to offer some guidance to employers as well. That's going to be a huge issue going forward, I think.
Brilliant, thank you very much. And I think we've had a lovely smorgasbord of presentations this afternoon. Just ask if you can keep your questions coming in the chat. We're now going to have a plenary for about 10-15 minutes, and we'll pick some questions from the chat. But one area we haven't really touched on is how might we design services for younger people, and coupled with that, how might we encourage vaccine uptake and reducing the risk of long COVID? So I'm going to ask Rachel if she's got any thoughts about that, and then come on to Steve.
Sorry, can you just repeat the question? I was just answering a question in the chat box, sorry.
Sure. How might we design services for younger people? That's part one. And part two is how might we encourage vaccine uptake and reduce the risk of developing long COVID in all people, but particularly in younger people?
Great question about the kids. So Long COVID Kids is an organisation that was set up and co-founded by a mum who has COVID, long COVID, and a child. So they are now a charity, and they are part of the NHS England working groups looking at the 14, soon to be 15 paediatric long COVID clinic hubs we have across England. Sorry, I'm very England centric. So how can we design these services to meet the needs of children? Well, first of all, it's slightly different, isn't it? Because children will have to have their parents there. The parents are their caregivers. Sometimes other siblings are actually the caregivers if the parents also have long COVID. And we need to take education into this as well as social isolation. Digital platforms are again challenging for children and young people for governance and for things like safeguarding. So even virtual we've seen being used a lot in adult services, but there are slight limitations and differences there. But I think it's really speaking to you know, the organisations that exist, the patient support groups within your locality. How, for example, the Southwest service is based in Bristol. So for a child to get to Cornwall, to Bristol from Cornwall, you know, is very, very difficult. So we have to think about local-based solutions, as well as the commission of the long COVID clinics and speaking to people who actually have long COVID. Vaccine uptake, I think there's been some incredible work being done within local communities with religious leaders, with locals, youth support workers, etc. And of course, social media and getting the right messages out there. And I think you mentioned at the beginning, Ian, about the incidence of long COVID for people who had both vaccinations. I think we just need to get this message out loud and clear. You know, vaccines are and research is the way out of this pandemic.
Fantastic. Steve, anything that you would like to add to this? So two parts of the question: services for younger people and encouraging vaccine uptake.
So on the first part, so there are services that exist which Rachel's highlighted. So in London we have a virtual MDT made up from professionals from across trusts. The principle that we have is trying to support children and their families as close to home as is possible, because you know, London's not as big as the Southwest, but that journey can have implications. So it's trying to support people with their local clinicians, partly because they need to be able to access their more local treatment services as well. So there are multidisciplinary teams that do that, general practice and referral route by paediatricians into those. One of the challenges that we have to recognise is for children and young people, the prevalence seems to be much less than in adults, and that creates a challenge, because if you are say a general practitioner again, and you actually develop expertise by seeing things quite a lot, and it's quite tricky if you're unlikely to, you're only going to see very few of them. So that's part of the education piece that we've got to provide to support people in that context. And then just in terms of vaccination, you know, it's just important to understand that the lead decision makers are parents, and we've got to make sure that we're using shared decision making. I think what we've seen for the most part is making people do stuff doesn't provide a beneficial impact, and also being impatient and expecting everyone to do it yesterday compounds the problem. So through hesitancy, I think it's actually around supporting shared decision making and providing leadership rather than pushing.
Thank you, and very helpful to be reminded of that. I'm just going to switch tack slightly with a question for James and Razia, really just from two very different perspectives. So the question in the chat says, what about long-term myocarditis post-COVID? And the question is sort of aimed at would things like vitamin C, probiotics, vitamin D, selenium, would those things be helpful? And I'm going to ask James, first of all, to give us a medical perspective, and then Razia to give us her perspective. So, James.
Thank you for that question. I mean, the data and the information we have is obviously still evolving as to how to best manage this. I mean, I would say if an individual has confirmed myocarditis, i.e. inflammation of the heart muscle, they need to be under a specialist cardiologist for that. It's a potentially very significant and serious complication of COVID, and very sadly, in some occasions, can be associated with sudden very rapid heart rates and collapses and things like that. So I would suggest that yes, there may be a place for additional therapies such as vitamin therapies and supplements that you've talked about, but please only under the guidance of a specialist cardiologist, very carefully watching that condition.
Okay, Razia, anything that you would like to add to that?
Just to say that because I didn't actually have any problems with tachycardia or any sort of complications in that sense, I did increase my supplements with vitamin C, vitamin D, and I always sort of like have taken probiotics anyway, so I did sort of like try to take them more naturally by, you know, drinking kefir, using sauerkraut and those sort of food type of supplements, and it did help me. But I wouldn't sort of like, as a you know, it's been said already that I wouldn't advise anybody taking anything without medical advice, just in case they do have other issues that these vitamins or extra supplements might interact with. But for me, it did help, helped boost my immune system, I think.
Lovely. In the same vein, and perhaps I think this is going to be a question for Rachel to start with, and we'll see where we go from there. So the question is, I'm a frustrated 20-year-old woman who used to do a lot of running and perhaps suffering with post-exertional malaise and weakness and joint pain. And the question is, would I do better by switching to muscle bulk bodybuilding instead of trying to run? Rachel.
So as always, it's very difficult to answer and give personal advice without assessing someone, but the easy answer to that is no, probably not. How do I know that? Because we have been speaking to a lot of people and seeing a lot of people with long COVID and persistent symptoms where they have tried, who are very fit and healthy, marathon runners, for example, ultra marathon runners who have tried to introduce exercise back into their daily routine and crashed and burned. So the real advice is you just have to stop, you have to rest. You have to introduce activities and know your limitations. Fatigue diaries are really good for this. Activity diaries, introduce things gradually into your day, combined with the cognitive tasks we spoke about, and then slowly you will, you know, get on the road to recovery. The great news is that at 12 months, most people with long COVID will start to see a near or full recovery, and whatever that means to you is in terms of recovery, but you do just have to be patient and really give your time to recover. And nutrition, sleep, everything we said.
Lovely, thank you. I'm going to switch tack and line up Karen for some questions on the chat. So the first are occupational health physios being included in the programs you've described for providing work support, or is this, or will the clinicians get some bespoke training on that aspect?
So within our service, we do have some occupational health contracts, and we do have occupational health physios, and they have also had access and been trained in delivering the programme. So that will support people in certain areas. More widely, we'd be very keen to be involved with occupational health providers as well. I think it's all around that sort of education and guidance, really, and understanding what a phase return is. And certainly it's not the usual 3 days, even 3 weeks, it's more like 3 months. I think the other thing as well is the sort of, you know, the sick pay conditions, which really are forcing a lot of people back into the workplace who really shouldn't be going back. That's a wider issue, I think, for the DWP. I think that's going to hit in the long term, and something that will need to be addressed.
Fantastic. And if I could just ask for a brief answer to this question about when is the Connect Health Long COVID programme starting, and how can patients get referred? Is it being run nationally?
So currently it's not being run nationally. We're starting a small pilot in the northwest area, in the Haywood, Middleton and Rochsham area. Referrals will be coming in to us from the long COVID service in secondary care. And we've got another few services, one in Brent, which has just gone live, I think, last week. And we've a few other areas up and around the country that are looking. We're having a lot of people coming to us to see how we can deliver it. We have got that chronic pain self-management service running in a lot of areas, so hopefully we will be able to roll out this provision in other areas nationally.
And in terms of trying to spread your expertise, is there any merit in trying to set up, because you won't be the only provider clearly, is there any merit in trying to set up a network of community providers to share good practice? I don't know whether that's something that you'd be interested in doing.
I think we would definitely look at the sort of education, training, sharing best practice. Of course, that's a priority for all of us, and that's something that we would definitely be looking to do. Yes.
Lovely. Okay, so we're going to draw things to a close. I'm going to ask all our speakers for one sentence about one thing that you would change to improve outcomes for people with long COVID. And I'm going to take colleagues in the order that they've spoken. So Rachel, what would be your headline? Sorry, I haven't given you much time to think about that. What would be your headline?
All clinicians, please believe people when they're explaining the symptoms, whatever they are.
Fantastic. James?
Well, don't expect people to just continue to recover in some progressive, gradual pattern, and expect the unexpected in terms of setbacks in the recovery with this condition, is my experience.
Brilliant, thank you. Razia, any pearls of wisdom? So you're on mute.
I was going to actually say the same as Rachel, that please validate people when they do offer a range of symptoms. Everybody isn't the same. People have different symptoms, and to believe them and not give them the name of anxiety or depression. Fantastic.
Steve?
If you're seeing patients with long COVID, please do think about who you're not seeing and have a commitment to inequalities.
Thank you. And Karen?
Again, validate the experience, empower patients to self-manage and continue with that support.
Fantastic. So we're drawing to a close now. Please fill in the feedback survey. It'll take about 2 minutes of time. It will help us to improve our future events and understanding about what other topics you'd like to see from us. And I'd just like to thank all of you for joining the webinar today and for your questions. We've got a lot more questions in the Q&A, and our clinical colleagues on the call will endeavour to answer those, and we'll post the full answers on our website. A massive thank you to our speakers, very well prepared, very well delivered, and incredibly informative. So a big thank you to you, and to everyone on the call. We hope you can join us for another webinar in the future, and we've got the dates of our next webinars on the screen. Thank you very much.